Today we're going to go over sodium disorders, hyper and hyponatremia, potassium disorders, hyper and hypokalemia, and go over acid-base disorders, and specifically metabolic acidosis and alkalosis. So let's just jump right in and go to hypernatremia, which is the first one. Whenever I approach any electrolyte or acid-base disorder, I like to think of this physiologically because that's the easiest way to dissect out a case. And the first question I usually ask is, what's the homeostatic mechanism in the body, usually the renal one, that normally would protect us from this? So the question is, why don't we normally get hypernatremia? And the answer to this is because of two things. Firstly, that we can concentrate our urine, which is a product of the effect of vasopressin on the collecting ducts, and we can drink water, which I hear a lot of people doing right now. When we see a patient with hypernatremia, I usually ask two questions. Is the urine appropriately concentrated, and do they have access to water? So here's the first question, and the way that we answer this is to look at the urine osmolality. So a normal person should be able to concentrate the urine osmolality to greater than 800 milliosmoles per kilo in the setting of hypernatremia. So if you have a patient whose urine osmolality is greater than 800 and they're hypernatremic, it must be because they have a non-renal cause of the hypernatremia, which is either insensible water losses. So even as I'm speaking right now, I'm losing free water that's evaporating from my respiratory tract. Most of us, as you know, lose half a liter to a liter of essentially free water's insensible losses every day. So if we have no access to water, then over the course of a couple of days, we will lose enough water to become severely hypernatremic. That's one of the reasons why it's essential to drink water every day. But one can also lose free water from the GI tract. This doesn't happen in normal types of diarrhea like secretory diarrhea because the diarrhea in those cases is isotonic, but osmotic diarrheas can do this. So if you give a patient go lightly or lactulose, that can cause free water loss. Pure sodium intake usually doesn't cause hypernatremia in adults. In children, it can do because, for example, there have been cases where babies have been given formula that was inappropriately diluted and gotten too much sodium. And of course, babies can't tell you that they're thirsty, whereas in adults, if you took in too much sodium, you would automatically know to drink more water. On this side of the equation is the patient whose urine osmolality is inappropriately low. And in that setting, you know that the hypernatremia is because of free water loss from the kidney, from the urine. And there are essentially two reasons that can be account for that. One is obviously diabetes insipidus, which refers to the inability of the kidney to concentrate urine, and that can either be central, meaning that it's due to impaired secretion of vasopressin, or nephrogenic diabetes insipidus, meaning that the renal tubule isn't responding to vasopressin. The other major cause of renal water loss is osmotic diuresis. In essence, that there's an osmotically active substance that's in the urine and drawing free water along with it that's being lost out of the body. The most common cause is, of course, glucose, so patients who are hyperglycemic and having a glucose osmotic diuresis. A urea osmotic diuresis can occur, for example, in patients in the ICU who are getting fed very high protein supplements in their TPN, can sometimes have that. And when we give patients mannitol, they will have an osmotic diuresis. So all of these can cause mild to moderate hypernatremia. And again, in order for these to cause, all of these to cause hypernatremia, not only do these conditions have to exist, but the patient either has to have a lack of access to water or have an impaired sense of thirst. So elderly individuals, as you know, have impaired thirst sensitivity, so they're more susceptible to any of these disorders. I just wanted to spend a minute talking about nephrogenic diabetes insipidus, just to remind you that there are a list of causes of it that you should be familiar with, and these are the common ones. There are two electrolyte disorders that cause temporary impairment of renal concentrating ability, hypokalemia and hyperkalemia, and that's why polyuria is a common manifestation of those electrolyte disorders. Tubal-interstitial diseases, particularly those that affect the medulla of the kidney, can cause this. So the classic one is sickle cell disease, but all of these can do it. And of course, probably the one we see most commonly now is that due to lithium treatment. And then chronic renal failure can cause some mild impairment of concentrating ability. So you should bear these in mind. If you get a patient that looks like they have diabetes insipidus, the way we distinguish whether it's central or nephrogenic is by a water deprivation test. Essentially, we deprive them of water to make them hypernatremic if they aren't already. At that time, a normal individual would have already maximal secretion of vasopressin and should have maximal concentration in the urine. Patient with diabetes insipidus would not. And then the question is it because they have a lack of vasopressin? If so, if you replace it with an analog of vasopressin, desmopressin, or DDAVP, you should be able to raise the urine osmolality and concentrate the urine. And that would indicate that the patient has central diabetes insipidus. By contrast, if the kidneys are unresponsive to desmopressin and this fails to concentrate the urine, then they probably have nephrogenic diabetes insipidus. And this is about as much detail as you would be expected to know for the internal medicine boards. In terms of the management of hyponatremia, there are formulas, as you're aware of, for calculating free water deficit. You would not be expected to calculate this for the internal medicine boards, and I don't think they would supply you with the formula. But you have to have some idea of the principles behind correcting hyponatremia. And the first principle is that you don't want to correct it too fast. So as you lower the serum sodium and therefore the osmolality of the extracellular fluid, there's an osmotic imbalance between the extracellular and intracellular fluid, and so the potential for water to osmose from the extracellular fluid intracellularly, which could cause cerebral edema. So we try and minimize the rate at which we correct. And so a rough rule of thumb is to replace about half the free water deficit in the first 24 hours, not the whole thing, and to try and correct it by no more than about 0.5 millimole per liter per hour on average, at least in the first day. You need to remember that in addition to the free water deficit, there could be ongoing free water losses that need to continue to be replaced. And obviously, you would try and treat the underlying cause. That's straightforward for example, central diabetes insipidus, where you just give vasopressin. For nephrogenic diabetes insipidus, if you can't treat the underlying cause, there isn't usually any specific treatment, but there are a number of things that one can do to try and reduce the urine output and make these patients' lives a little better. So that's all I'm going to say about hypernatremia, and I'm going to move straight on to hyponatremia. So when you see a patient with hyponatremia or get a question on the boards about hyponatremia, the first question is, does this hyponatremia reflect a reduction in plasma osmolality? If so, meaning the plasma osmolality is less than about 275, then this is true hypoosmolal hyponatremia. But there are a number of conditions that can mimic this. For example, patients who are hyperglycemic will have hyponatremia. They're not hypoosmolar. In fact, they are hyperosmolar. And that's in part because glucose in the blood causes shifts of water out of cells. And so you should all be aware that where it's recommended to correct the apparent, the actual serum sodium by adding 1.6 for every 100 milligram per deciliter, the glucose is increased. And that'll tell you whether this patient truly has underlying hyponatremia, if you will. Mannitol does a similar thing. In the middle here is patients whose plasma osmolalities are perfectly normal but have a lab artifact which we call pseudohypernatremia. This is relatively rare now with modern methods of measuring serum sodium, but it can still occur under rare circumstances. So if you see a patient that has severe hyperlipidemia or hyperproteinemia, it's possible that they have pseudohypernatremia. But focusing on hypoosmolar hyponatremia, which is the most important one, there are 4 things that I usually do to evaluate a patient of hypoosmolar hyponatremia. Determine volume status clinically, measure the urine osmolality, measure the urine sodium, and then do additional endocrine tests. 4 things. So this is how volume status helps us. So patients who are hypovolemic can develop hyponatremia. As you recall, vasopressin is released not only in response to high osmolality, but also in response to severe volume depletion. So patients who are volume depleted because they have diarrhea or vomiting, if it becomes very severe, can then develop hyponatremia. If they have volume depletion because of renal salt wasting, either from Addison's disease or treatment with diuretics, particularly thiazide diuretics, they can also develop hyponatremia. Over on this side are patients who are not volume depleted. They're actually edematous, but they have reduced perfusion to their kidneys and peripheral organs, and we call this effective circulating volume depletion. So patients with cardiac failure and liver failure behave as if they're volume depleted, even though they aren't actually. And so the kidney responds to this apparent volume depletion, and vasopressin responds by being released, and they concentrate the urine and become hyponatremic. And in the middle are the patients who are euvolemic. This includes psychogenic polydipsia, patients who are drinking enormous amounts of water. SIADH, which we're all familiar with, syndrome of inappropriate ADH secretion, which can be caused by CNS disorders, lung disorders, and medications, and hypothyroidism. So first we look at the volume status, then we measure the urine osmolality. So in this whole list, there's only one disorder in which the urine osmolality is appropriately dilute, okay? And that's in psychogenic polydipsia. What do I mean by appropriately dilute? If a patient is if you made me or a normal individual hyponatremic, we would try and correct that by profoundly diluting our urine and getting rid of free water. How much can we dilute our urine? Less than 100 milliosmoles per kilo. So if you have a patient who's able to dilute their urine adequately and they're still hyponatremic, it must mean that they're drinking water faster than the rate at which they're getting rid of it in their urine. And that usually means at least 1 liter an hour, which is 20 plus liters per day. And so you pretty much have to be psychotic to want to do that. So hence the name. And then finally, the third thing we do is to measure the urine sodium. This is just a clue to volume depletion. So patients who have extrarenal dehydration or effective circulating volume depletion will have low urine sodiums, meaning less than 20. However, if the volume depletion is due to renal salt loss, like Addison's or diuretics, then conversely, the urine sodium would actually be high. And then finally, in purple here, I list the 2 endocrine disorders, Addison's and hypothyroidism, which may not necessarily be evident clinically. And so, as a general rule, unless you have an obvious cause for the hyponatremia, it's always good practice to check a cortisol and check a TSH. In terms of treatments of hyponatremia, if patients are hypovolemic, we usually just treat with isotonic saline. As the volume recovers, they manage to dilute their urine adequately. Obviously, a patient who's polydipsic should have water restriction. The patient with SIADH is probably the most difficult to treat. If they have mild SIADH, we treat them with water restriction. If they have more severe SIADH, you have to give them salt in excess of water and or dilute down their urine. And as you're aware, there's now a group of drugs that block the ADH receptor, which we go under the name of Vaptans, which can potentially reverse the effects of SIADH. So a common issue that comes up that you need to be aware of is what's the appropriate rate of correction of hyponatremia. And the answer to that is it depends on whether the hyponatremia is acute or chronic. So in chronic hyponatremia, the brain actually adapts to the chronic hyponatremia by reducing the osmolality of the intracellular fluid. And in that case, if you correct the hyponatremia too rapidly, you can get complications, which we'll get to in a moment. So in chronic asymptomatic hyponatremia, it's recommended that you correct no more than 0.5 milliequivalent per liter per hour in the serum sodium, and most importantly, don't exceed a correction of more than 12 in the first day. In acute hyponatremia, the brain has not had time to adapt to it. And those are really the patients that are going to get complications from the hyponatremia, which are cerebral edema, seizures, and herniation. And those patients need to be treated rapidly. And there are a variety of protocols for how to treat it. One of the more common ones that's been touted in recent years is to give a hypertonic saline bolus of 100 mils, which increases the serum sodium by about 2 to 3, which seems to be just enough to get patients out of trouble. For the purposes of the board, you won't be expected to calculate how much sodium to give. In general, hypertonic saline is something that's mostly given by nephrologists, and we're supposed to spend some time calculating carefully how much to give. But for the purposes of the board, you just have to be aware that there's a significant difference in how you treat an acute and a chronic hyponatremic and the urgency of treating it. The other thing that you need to be aware of is what the complication of over-rapid treatment in chronic hyponatremia is, and it's what we now call osmotic demyelination syndrome. And it's basically myelinolysis both of the central pons and also of extrapontine sites. So this used to be called just central pontine myelinolysis, or CPM, but it's now clear it also affects extrapontine sites. The major risk factor is an excessive rate of correction of serum sodium. Other risk factors include being alcoholic and having severe liver disease post-liver transplant. In the classic pontine type, you get dysphagia and quadriparesis in locked-in syndrome, and in some cases this is permanent. So this is a really devastating disorder, and that's why we take such great pains to try and make sure we prevent it. Fortunately, in the current era, it's pretty rare. So that's essentially all I'm going to say about hyponatremia, and we're going to move on now to potassium disorders. And first, hyperkalemia. So when you see a patient that's hyperkalemic, it should at least run through your mind the possibility that there might be pseudohyperkalemia, either because the blood sample was hemolyzed when it was being drawn, or because of severe leukocytosis or thrombocytosis. So this usually only occurs with patients with leukemias or essential thrombocytopenia, in which the cells, you have a large number of these cells in the blood, and during the time when they clot in vitro, they release their intracellular potassium. If you suspect this, and this usually only occurs with severe leukocytosis and thrombocytosis, so white counts of over 100 or 150. And if you suspect this, the two ways to check this are to check the EKG. So a patient who's normal kalemic normally, who now has an apparent potassium of 7 or 8, should have some EKG changes. So if there aren't any, that would clue you in that This was pseudohyperkalemia. And to check potassium another way, and currently, in the current era, probably the easiest way is to do a whole blood potassium and run it through a blood gas analyzer. And so if there's a pseudohyperkalemia, in that case, the potassium would come back normal. If you have real hyperkalemia, the causes can be one of the following. So increased intake, usually not in and of itself a major cause because you would be able to excrete that, but obviously if you have other reasons to be unable to excrete potassium, then increased intake could be a problem. Decreased urinary potassium excretion and shift of potassium out of cells. And the way that we diagnose decreased urinary potassium excretion is by looking at urinary potassium. You're probably aware that there are a whole host of different tests that have been touted for measuring this. For the purposes of the boards, the test that's usually will appear most commonly is a 24-hour urine potassium. Even though in clinical practice, this is a big pain to collect a 24-hour urine. But this is what they would show you if they were going to show urinary potassium. And generally, in the setting of hyperkalemia, a normal person should be able to increase their urine potassium well above 40 milliequivalents per day to try and get rid of the potassium. Therefore, if this is significantly less than 40, it suggests that there's urinary potassium retention. Going over to the right here and running through the list of things that shift potassium out of the cells, metabolic acidosis is one that everyone remembers. It's probably the least important one in and of itself. But in general, hydrogen ions and potassium ions can exchange across the plasma membrane of cells. So metabolic acidosis in and of itself can cause a mild hyperkalemia. Hyperglycemia causes hypokalemia. As it draws water out of cells, potassium can come out by osmotic shifts. Beta blockers, particularly beta 2, so non-specific beta blockers that affect the beta 2 adrenergic receptor, will inhibit the sodium pump of cells and can cause some mild hyperkalemia. Digitalis blocks the sodium pump. If you have severe digitalis poisoning, you can get hyperkalemia associated with that. Rare and usually a very bad prognostic indicator. There's an extremely rare disease called hyperkalemic periodic paralysis that is genetic and can cause high potassiums with paralysis. And this is extremely rare as opposed to hypokalemic periodic paralysis, the apparent same disease but with low potassium that I'll talk to you about in hypokalemia, which is actually quite common. And then because potassium is mostly sequestered within cells, cell lysis syndromes can cause hyperkalemia. So lysis of muscle cells, rhabdomyolysis, and lysis of red cells, hemolysis, or lysis of tumor cells. So tumor lysis, rhabdomyolysis, hemolysis, all of them cause hyperkalemia. If you get a case where you diagnose decreased urinary potassium excretion, then the causes are listed, common causes are listed here. So this either means that in general your GFR and renal function are reduced, so patients with renal failure obviously can get hyperkalemic, or you have a specific defect in the ability of the collecting ducts of the kidney to secrete the potassium. So as you recall, in the collecting duct, sodium is reabsorbed electrogenically, meaning that as it's reabsorbed, it generates a lumen negative electrical potential that drives potassium secretion, and this is all stimulated by aldosterone. So all of these conditions either block the ability of aldosterone to act on the collecting duct, or they block that sodium channel. So in terms of medications that you should run through that cause hyperkalemia, all of these inhibit the renin-angiotensin-aldosterone system. NSAIDs, ACE inhibitors, ARBs, heparin, which blocks synthesis of aldosterone, spironolactone and eplerenone, obviously aldosterone antagonists, and cyclosporin, which seems to cause a hyporeninemic, hypoaldo type state. Amiloride and Triamterene directly drugs that are designed to block the sodium channel in the collecting duct. But as Dr. Tucker mentioned in the last lecture, high doses of trimethoprim or pentamidine can also inadvertently block the sodium channel and cause hyperkalemia. Obviously, adrenal insufficiency itself is associated with hypokalemia. And then there's this disorder called hyporeninemic hypoaldosteronism that can also do it, and which I'll talk about next. So, hyporeninemic hypoaldosteronism is a form of type 4 renal tubular acidosis. We'll get to RTAs in a second. The main manifestation of it is that these patients often have some mild renal insufficiency, but the hyperkalemia is disproportionate to the level of GFR. In some cases, they can have a non-GAP metabolic acidosis, but it's usually quite mild, and sometimes it's completely absent. They have mild CKD, and there's specific disorders that affect the tubular interstitium that cause this, and probably the most common is diabetic nephropathy. So we generally suspect this clinically if we see, for example, a patient with diabetic nephropathy who has disproportionate hyperkalemia. There are a list of other renal disorders that can primarily affect the tubular interstitium, and this can be directly mimicked by NSAIDs, which also inhibit renin secretion and can give a very similar picture. When we have a patient with hyperkalemia, the treatment strategies, hopefully you're all quite familiar with. If you have a patient that has EKG changes or has developed arrhythmias, the first important step is to stabilize the cardiac membrane by giving calcium, either as calcium chloride, which needs to go through a central line, or calcium gluconate. These are given in 1 gram ampules. You can temporarily reduce your serum potassium by shifting it into cells, either by giving insulin glucose, giving a beta-2 adrenergic agonist, for example, nebulized albuterol, noting that the dose that we're giving here is about 2 to 4 times the dose that you give for asthma or COPD. And in patients with acidotic, sodium bicarbonate can help a little. But the important thing is that although these work pretty quickly in a matter of minutes, they're transient. Potassium will eventually come out of the cells, usually after 2 or 3 hours. And so ultimately, if you need to get rid of the excess potassium in the body, you need to do something else. And that's either giving a cation exchange resin, like Kxalate, which is sodium polystyrene sulfonate, giving diuretics if you think they can respond to it, or dialyzing them if they have renal failure. And then chronically, of course, the other thing that's always important is to remember that a great part of this potassium is coming from the diet, and so dietary potassium restriction is very important in controlling chronic hyperkalemia. Okay, moving on to hypokalemia. You can see there's a little bit of symmetry in how we approach all of these. So hypokalemia can also be caused by cellular shift, by GI losses, or by urinary K wasting. Over here on the left, I've listed the causes of cellular shift in potassium. So again, alkalemia, because protons and potassium can exchange across the cell membrane, can in and of itself cause hypokalemia mildly. Insulin directly stimulates potassium entry into cells. So, for example, when you have a patient with diabetic ketoacidosis, you'll notice that when you actually give them insulin, their serum potassium often drops quite precipitously. I mentioned to you that we use albuterol to treat hypokalemia. So any beta-2 adrenergic agonist is going to drop the potassium. And then there's this disorder that's called hypokalemic periodic paralysis that can cause hypokalemia. And so this is something that you should be aware of. It does come up quite frequently in the boards because it's actually relatively common, and it comes in 2 forms. One which is inherited and due to mutations in muscle ion channels, and there's also an acquired type that appears to occur when individuals develop thyrotoxicosis. And for some reason that we don't at this point understand, it's particularly much more common in males and particularly common in Asian ethnicity. It's precipitated by meals or exercise. So these meals would obviously increase insulin, exercise would increase adrenergic sympathetic tone, and so either of these would stimulate, initiate, if you will, shift of potassium into cells that then continues, and then they can present with acute profound hypokalemia. Some of these patients present with potassiums in the ones, which can be quite alarming if you see it in the emergency room. And of course, they have a profound flaccid paralysis along with it. But the important thing is that the serum potassium can recover spontaneously. So they don't have whole body potassium depletion. It's just all shifted into cells. And why that's really important is that if you respond to a serum potassium of, say, 1.5 by giving them massive amounts of IV potassium, then when they recover, they're going to become severely hyperkalemic. And so the idea is to try and recognize this and avoid this. So they can recover the potassium spontaneously, usually within hours. Some people give propanolol, which seems to accelerate the recovery. If you check the urine potassium, it would be low. So these are patients who are responding to the hypokalemia by retaining potassium from the kidney, and that's a clue that this might be the cause. So if you see a patient like this, don't jump to repleting them with huge amounts of potassium. So those are cellular shift. Here are the causes of actual potassium depletion from the body. There are GI causes, vomiting and diarrhea, and urinary causes, which would cause urinary K wasting. So in the setting of hypokalemia, normally we would attempt to correct this in the kidneys by retaining potassium and minimizing excretion of potassium. So normal individuals should be able to lower their urine potassium to less than 25 milliequivalents or millimoles per 24 hours. So if you see a patient that's hypokalemic and their 24-hour urine potassium is a lot more than 25, it suggests that they have renal K wasting. At this point, I just want to mention one little anomaly here that is worth remembering. I put vomiting here as a GI cause because that's how I like to remember it, along with diarrhea. But vomiting doesn't actually cause GI potassium wasting. So it turns out that gastric fluids have very, very low concentration of potassium. But the reason that patients with vomiting do develop K wasting is because they become profoundly alkalotic and alkalemic, and as they do so, the alkalosis and alkalemia causes urinary K wasting. So in fact, their urine potassium would, if anything, be high. It's a minor point and shouldn't come up in the boards, but in case you see this in the textbooks and it confuses you, that's the reason for it. Assuming that you have a patient that has inappropriate renal K wasting, how do we figure out what the cause is? And I usually divide it into two general groups of patients, those that have hypertension and those are normotensive. And this is the group of patients that have hypertension, hypokalemia, and renal K wasting. And they typically have hyperaldosteronism. What do I mean by that? I mean that either their aldosterone levels are high, which as we discussed causes sodium retention, hence hypertension, and secondarily increases K secretion, or that they have a condition that mimics high aldosterone levels. So the classic cause of this is primary hyperaldosteronism, or Conn's syndrome. Can be caused by either an adenoma or hyperplasia of the adrenal glands. And in that setting, your plasma aldosterone level is high, and this feeds back to renin and suppresses it. So you'd have a low renin and a high aldosterone level. And in fact, the way that we often screen for this is to measure the aldosterone to renin ratio in the blood, which would be extremely high in these patients. On the left here, we have patients that have secondary hyperaldosteronism. So they have high renins, and that then causes the high aldosterone, the hypertension, the hypokalemia. And the only really common cause of that is renal artery stenosis. So as your renal artery narrows, the kidney senses decreased perfusion pressure and responds by releasing more and more renin, which then in turn acts on angiotensin and aldosterone to increase those. And then over on the right here are patients whose renins and aldos are both low, but they behave as if they were hyperaldo. And the most common cause of this is Cushing's syndrome. So it turns out that cortisol and glucocorticoids can actually act on the mineralocorticoid receptor in the kidney and do the same thing as aldosterone. But this doesn't usually manifest clinically unless you have very, very high cortisol levels. So if you have pathologic cortisol levels in Cushing's syndrome, you can get a hyperaldo-like state, but with the aldo and renin levels suppressed. There are a number of other causes. Some of them are quite rare, unlikely to come up in the internal medicine boards. Conversely, if you have renal K wasting and your blood pressure is normal, these are the causes. And so I've listed them according to some general categories, which are osmotic diuresis. So if you have a hyperglycemia, chronically you would lose potassium. There are certain drugs that do this. Some of these are familiar to you. Vomiting, I mentioned, causes renal K wasting. Renal tube acidosis. There are two hypokalemic types, proximal and classic distal, and we'll get to that later. And inherited tubulopathies like Barter's and Gittleman's. These are particularly important to focus on for a second. So one of the common ways that we see renal K wasting is when there is inhibition of sodium reabsorption in tubule sites that are proximal to the collecting duct, like the thick ascending limb and the distal convoluted tubule. So if you give a loop diuretic like furosemide or a thiazide diuretic like hydrochlorothiazide, those inhibit sodium chloride reabsorption in the thick ascending limb or the distal convoluted tubule. Hence, more sodium is delivered to the collecting duct where it's reabsorbed in exchange for potassium secretion, and that causes hypokalemia. Barter's and Gittleman's behave exactly the same way. They're inherited disorders of defective sodium chloride reabsorption in the thick ascending limb, like loop diuretics, or in the distal convoluted tubule, like thiazide diuretics. And the importance of emphasizing this is the clue that this is happening is that when you measure urine, usually urine chloride, it'll be high. Why do we measure urine chloride? Well, most of these patients with hypokalemia will also have a metabolic alkalosis. Now, we're all used to measuring urine sodium and using that as a marker of volume status. Well, it turns out in the setting of metabolic alkalosis, urine sodium is no longer a good marker of hypovolemia, whereas urine chloride remains a good marker. And so in general, we use urine chloride instead of urine sodium to look for patients with hypovolemia. So if a patient has low urine chloride, it indicates that they have hypovolemia due to extrarenal causes. So someone who's vomiting or is having diarrhea would have a urine chloride. On the other hand, if you have a high urine chloride, then it could suggest that that patient has renal salt wasting. And that brings me to the cheat sheet, if you will. So most patients with hypokalemia, it should be pretty obvious why they have the hypokalemia just on the basis of history and exam. If you can't figure it out and they have hypokalemia and metabolic alkalosis, these are the most common things that cause this that are otherwise difficult to diagnose. So they could have an undiagnosed hyperaldosteronism. As I mentioned to you, those patients should have hypertension. They could have surreptitious vomiting. The clue here is that the urine chloride would be very low. Or they could have diuretic abuse, Barter's or Gittleman syndrome, which would look just like surreptitious vomiting, except that the urine chloride will actually be high. How high? More than 40 milliequivalents per liter. Now, how do we distinguish between diuretics and Bartels and Gittelmans? The answer is it's sometimes very, very difficult. You can try and measure urine diuretics if you can catch them when they're taking them, but sometimes it requires a little bit of detective work. So that's all I'm going to say about potassium. In the last 20 minutes, I'm going to talk about acid-base disorders and breeze through these. And because of lack of time, I'm going to be fairly brief with the general approach because this should be very familiar to you. In essence, there are 3 steps to the general approach to any patient of acid-base disorder. You want to ask, what's the primary change in the pH? Is it acidemic or alkalemic? You can only be one or the other. Then you want to ask, what's the underlying primary process? That's what these OCs are, metabolic or respiratory acidosis or alkalosis. And as you know, you can have just one of them or 2, or you can have a mixture of any number up to 4, all acting on the pH. And then finally, for each primary process, the question becomes, is there an appropriate compensatory response? And if there isn't, then that would suggest to you that there may be more than one primary process. So is there acidemia or alkalemia? We look at the urine pH to answer that. What is the primary process? This is the Henderson-Hasselbalch equation, which shows that because bicarbonate CO2 is the major buffer in the blood, changes in bicarbonate and PCO2 report on the state of the acid-base balance in the body. You don't need to know this equation. You're not going to be asked to calculate any of these in the boards, but this is to show you that bicarbonate is on the numerator, PCO2 on the denominator. Metabolic processes will cause a change in the bicarb. Respiratory processes cause a change in the PCO2. If the bicarbonate goes up, the pH goes up. Alkalemia. If the PCO2 goes up because it's on the denominator, pH goes down. Respiratory acidosis, and so on. And so that's how we figure out whether the primary disorder is one of these 4 processes. The next question is, what's the appropriate compensatory response? So if we have a metabolic acidosis and the bicarb goes down, we expect the PCO2 to go down. In other words, that we will breathe faster, which we call Kussmaul's breathing, in order to try and breathe down the CO2 and partially correct the pH. So in essence, we're causing, if you will, a respiratory alkalosis, but we don't call it a respiratory alkalosis. We call it respiratory response or respiratory compensation for a metabolic acidosis, as opposed to primary respiratory alkalosis, which would suggest there's an additional disorder causing rapid breathing. Similarly, if you have a primary respiratory alkalosis, the kidneys would respond by trying to get rid of bicarbonate in the urine and lower the serum bicarbonate. Metabolic alkalosis, we would respond by lowering ventilation rate. This is a limited response because obviously ventilation rate is also driven by hypoxia. And if you have a respiratory acidosis, the kidneys respond by retaining bicarbonate to correct that. You will not be expected to remember the quantities for the compensation. Most of us carry in our handbooks tables that allow us to calculate the compensation, or a so-called acid-base map that's quite useful clinically. They won't ask you to do that in the boards, but you do need to know some rough general principles. And the first is you need to remember the direction of the compensation. So the compensation seems to be in the wrong direction. That would be a clue that there's another primary disorder. And the other thing to remember is that compensation is almost never complete. So if you have a primary metabolic acidosis, lowering your bicarb, and you respond by compensating by breathing faster and heavier to try and return that pH back to normal. It's not going to return it completely back to normal. It's just going to return it part way there, and the patient is still going to be acidemic. So if you have a patient whose pH is completely normal, that only means one of 2 things. Either they don't have any acid-base disorders, or they have 2 counterbalancing primary disorders, one of which is attempting to raise the pH, and one of which is trying to decrease the pH. Okay, so moving on to metabolic acidosis. When you see a patient with metabolic acidosis, there are two general groups of disorders that cause this. Ones that raise the anion gap, which are essentially disorders where the acid that's ending up in the blood comes with any anion other than chloride, such as lactate or keto acid, etc. So that would make the anion gap go up, and then the other group of disorders are those where the anion gap is normal. So the first step is always to measure, to calculate the serum anion gap, which is simply the sodium minus sum of chloride and bicarbonate, and the normal range is approximately 8 to 12. The causes of high anion gap metabolic acidosis we're all very familiar with. We all remember, I'm sure, the mnemonic mud piles, which stands for methanol uremia, which is renal failure, diabetic ketoacidosis, paraldehyde, iron or isoniazid, lactic acidosis, ethylene glycol or ethanol, and salicylates. Paraldehyde, iron, and isoniazid, very, very rare causes of metabolic acidosis. In fact, I don't know, are there any individuals in the room who still remember using paraldehyde? No, afraid not. Used to be used in the old days for treating patients with seizures quite a lot. So you're not going to see those. But over on the right here are some more modern causes of high anion gap metabolic acidosis that haven't made it into the mnemonic. And if anyone comes up with a really cool mnemonic that includes it, let me know. But those include rhabdomyolysis, glue sniffing or toluene abuse. I included type B lactic acidosis, even though you have lactic acidosis here. So type A lactic acidosis is what we usually think of, lactic acidosis associated with decreased tissue perfusion and tissue ischemia. Type B lactic acidosis is that associated with not associated with hypoperfusion, usually due to meds. The common ones are metformin and various types of HIV drugs that we'll get into in a moment. There is also another type of lactic acidosis called D-lactic acidosis that's quite rare. So normally all of the amino acids in our body are L isomers of amino acids, and lactic acid in our body is always an L isomer. So D-lactic acid is generated by bacteria in our gut, and in certain conditions it can rise in the body, and because it's not measured, when you normally send a lactic acid level to the lab, you have to suspect it and send the D-lactic acid to diagnose that. And then propylene glycol, as I'll get to, is something that you would only see predominantly in the ICU. A lot of patients come in with metabolic acidosis in the ER after an intoxication, and in that setting it is routine to measure the serum osmolality and calculate the osmolar gap. And this is really critical for diagnosing these disorders. So the reason we do this is because small alcohols like ethanol, ethylene glycol, propylene glycol, and methanol, which are uncharged, all increase the osmolality of the serum, sometimes quite markedly. So it's a great clue that you have these in the blood. These also get metabolized or cause an anion gap acidosis. So ethylene glycol is metabolized to glycolic acid and oxalic acid. Propylene glycol is metabolized to lactic acid. Methanol is metabolized to formic acid. Ethanol causes alcoholic ketoacidosis. So these all also cause an anion gap acidosis. And this is in contradistinction to salicylate poisoning, for example, which causes an anion gap acidosis, but because it's charged and present in low concentrations in the serum, it does not raise the osmolar gap. And over here is another alcohol, isopropanol, that also increases the osmolar gap, but is not metabolized to an acid, and so therefore does not cause an anion gap acidosis. So by measuring the osmolar gap and looking for an anion gap acidosis, you can differentiate between these three classes of intoxications. How do we do this? to calculate the predicted serum osm from the blood, we need to calculate the contributions of sodium, glucose, and urea to this. And the way we do this is twice the serum sodium in millimoles per liter, divide the glucose in mg per deciliter, divide it by 18, and divide the BUN by 2.8. And that gives you the calculated serum osmolality. We measure the serum osmolality by sending it to the lab. This is done by freezing point depression. And the difference between them represents the gap. So if you have something like methanol in your blood, the measured serum osm will be much higher, but the calculated serum osm predicted just from the sodium, glucose, and BUN should be relatively normal, and so there would be a difference. Normal osmolar gap should be less than 10. If you have an osmolar gap of greater than 10 milliosmoles per kilo, that suggests that you have an additional osmotically active substance, which in the setting of an anion gap metabolic acidosis would be ethanol, methanol, propylene glycol, or ethylene glycol. So just to run through these, so these are so particularly what you will be given in the boards are relatively stereotypic situations which you should be able to recognize on the basis of just the description. So a patient who has alcoholic fetor, has some eye changes, changes in vision or papilledema, an osmolar gap and a high anion gap acidosis, but when you measure the ethanol level, it's undetectable. They probably have methanol poisoning. Where do we get methanol from? It's a cheap form of alcohol. It's used in a lot of solvent-based fluids, like, for example, windscreen wiper fluid. By contrast, if you have a similar syndrome, but you don't smell any alcohol on the breath at all, and you see calcium oxalate crystals in the urine, here are calcium oxalate dihydrate crystals. They appear envelope-shaped, and the urine fluoresces under UV lamp. Those patients might have ethylene glycol poisoning. And the reason it fluoresces is the most common cause of ethylene glycol poisoning by far is from antifreeze used in coolants, fluid put into cars. And coolant fluid, they often put in fluorescein as well, which car mechanics apparently use to diagnose leaks in the car. And so that would appear in the urine and cause the urine to fluoresce under UV light. The ethylene glycol itself, as I mentioned, is metabolized to oxalic acid, and so that would precipitate with calcium and cause calcium oxalate crystals. A patient who develops tinnitus and deafness, they have the tachy temperature, pulse, and respiration. That's how I like to think of it. The temperature is up, the pulse is up, the respiratory rate is up, and they have a mixed acid-base disturbance, particularly associated with a primary respiratory alkalosis and often with a metabolic alkalosis as well. That's a clue that this might be a patient who has salicylate intoxication. If you have a patient who has ketoacidosis, where the ketone that's positive is predominantly beta-hydroxybutyrate, whereas the acetoacetate measured with an acid test or direct measurement of acetoacetate is either negative or just very low, might clue you into alcoholic ketoacidosis, particularly if the glucose is normal. And don't be fooled by the serum ethanol. Most patients that have alcoholic ketoacidosis, by the time they present with this, they already stopped drinking and have normal serum ethanol levels. An HIV patient who's on didanosine or stavudine can develop a severe lactic acidosis. This is not acute. This is usually quite chronic, occurring over weeks to months. It's exacerbated if they use tenofovir, which actually increases the area under the curve of DDI. And these patients develop liver failure and eventually multi-organ failure and have a very high mortality. If you have a patient that has short bowel syndrome from some sort of surgery and they recurrently come into the ER with episodes of change in mental status with an anion gap metabolic acidosis that spontaneously resolves, and they have a completely negative workup, they might have D-lactic acidosis. So this is made by the bacteria that proliferate in the gut and short bowel syndrome. And they have episodes where when they take in carbohydrate, the bacteria metabolize this to lactic acid and it's absorbed into the blood and causes a change in mental status. When they're brought into hospital and made NPO, it resolves spontaneously. And finally, if you have an ICU patient who's sedated with very high doses of Ativan or lorazepam and develop an osmolar gap metabolic acidosis with high lactic acid levels, they could be intoxicated with the vehicle that's used in the Ativan drip, not the Ativan itself, which actually contains propylene glycol, which is in there because it's supposedly inactive, but in fact it can be metabolized to lactic acid. Okay, so moving on. So the other major cause of a metabolic acidosis is non-GAP, and this is really easy because the differential is just diarrhea or renal tubular acidosis, and it should be pretty obvious if they have diarrhea. If they have a renal tubular acidosis, the three types that you need to know about are classic distal, proximal, and type 4, which is usually hyporeninemic hypoaldosteronism. And this is the simplified version of how to diagnose an RTA. If you go and look in the books, you'll find some very complicated differentials. You don't need to know all of that. This is the simplest way to diagnose it, certainly for the purposes of the boards. So these two have low serum potassium, hyporeninemic hypoaldo, the potassium is high. The urine pH is usually high in classic distal, so that's the reason that they have the RTA, is they can't acidify their urine appropriately, meaning to a pH of less than 5.5. By contrast, patients with hyporeninemic hypoaldosteronism can acidify their urine just fine and lower their pH to less than 5.5. But the reason that they become acidotic is because they can't generate enough ammonium and excrete that. And as you may recall, ammonia is the major buffer that gets rid of large amounts of acid from the body. Proximal RTAs can be complicated to diagnose. The urine pH can be variable, but the clue is that particularly in adults, essentially all patients who are going to have a proximal RTA, and certainly all the ones that they'll present to you in the boards, they'll present you a patient that has other manifestations of a proximal tubulopathy, essentially Fanconi syndrome. And the major clues that you'll see are low phosphate, glycosuria, and maybe amino aciduria. And here are some of the more common causes that you should remember. So there are a bunch of drugs that can cause proximal RTA. Classic distal RTA is most commonly caused by autoimmune disorders like lupus and Sjogren's, but can be mimicked by drugs like amphotericin. And I mentioned already hyporeninemic hypoaldosteronism. So finally, in the last couple of minutes, metabolic alkalosis. The causes are, again, fairly obvious. Either you're ingesting alkali from antacids or blood transfusion, which contains a lot of citrates, or you're shifting acid into cells, which can be caused by hypokalemia, usually a very mild cause, or you're losing acid from the body, either in the GI tract, vomiting or NG suction, obviously a very common cause, or from renal losses. So again, the same causes for hypokalemia are also causes for metabolic alkalosis, diuretics, Bartels and Gittelman's hyperaldosteronism. And that's because in the collecting duct, when we reabsorb sodium, we not only stimulate K secretion, but we also stimulate secretion of acid at the same time. And again, all of that is stimulated by high aldo levels. So all of those causes of a hypokalemic metabolic alkalosis are causing not only increased K secretion, but also acid secretion. Once you cause an alkalosis, there are a number of conditions that cause us the alkalosis to be maintained. So volume contraction, and the reason for that is as you become more volume contracted, you release more aldosterone, which again stimulates more sodium reabsorption and hydrogen excretion. So this is part and parcel of vomiting and diuretics. Hypokalemia, renal failure, so if you don't have enough renal function, you can't get rid of your excess alkali, and hyperaldosteronism. And I put these three in green because it's important to remember that these are three potentially reversible causes. So if you have a patient of alkalosis from whatever cause, if you can correct the volume contraction, if they have that, or correct the hypokalemia, or correct the renal failure, they may be able to get rid of the excess bicarbonate and automatically correct their own alkalosis. In terms of diagnostic dilemmas, again, if you have a patient who has a hypokalemic metabolic alkalosis and you can't figure out why they have this, they either have hyperaldosteronism that hasn't been diagnosed, they're secretly vomiting and not telling you, they're secretly abusing diuretics, or they have Barters and Gittlemans that no one had previously suspected. And again, the blood pressure, the urine chloride, and urine diuretic screen can help you distinguish between those. Finally, we have a couple of sample board review questions for you. The first one is a 26-year-old healthy male who presents with a seizure. Serum sodium is 115, urine sodium is 30, osmolality is 45. What is the most likely diagnosis? SIADH, hypothyroidism, psychogenic polydipsia, cirrhosis, or adrenal insufficiency. And if you just hone in on the urine osmolality of 45, which is appropriately dilute, this already clues you in that this has to be psychogenic polydipsia. Which is C, answer C. And sample board review question 2, a 75-year-old male with known coronary and peripheral vascular disease presents with worsening hypertension despite treatment with thiazides, amlodipine, and candesartan. And his K is 3, bicarb is 29. Which diagnostic test is most likely to be useful? So this is a patient that has hypokalemic, metabolic alkalosis, and hypertension. So this patient has hyperaldosteronism of some sort. The major differentials, renal artery stenosis, primary hyperaldosteronism, or Cushing's. And in this particular setting, it sounds like this patient probably has renal vascular disease. And so the correct test would be E, a Doppler ultrasound of the renal arteries. And here's some suggested reading. Thank you.
This is a question for Sus Waker. Sus, what about the use of diuretics in patients with acute kidney injury? Do you use diuretics for the treatment? We've heard that that some people don't recommend the use of it. What do you do?
I think they don't have a role in the prevention of acute kidney injury, for example, prior to contrast administration. In the setting of established acute kidney injury, it's very common to use high-dose diuretics to convert non-oliguric to urine, to increase urine flow rate. There's no great evidence for it. There is a JAMA article from 2007 suggesting that diuretics in the setting of AKI are associated with higher risk of in-hospital mortality. But I think most of us in the setting of someone who is oliguric and has severe AKI, we would first try a trial of high-dose diuretics to see if we can get urine flow going prior to initiating hemodialysis. So.
Another question for you. Patients with contrast nephropathy, there's a lot of literature about what's the appropriate way to provide prophylaxis. Some have argued for the use of N-acetylcysteine, and others for sodium bicarbonate. And what's the right answer for the boards, and what's the right answer in your clinical practice?
Yeah, the right answer for the boards, I'm not sure. I guess it may change this year versus next. This is a moving target. The most recent large trials have actually not borne out the benefits of sodium bicarbonate and N-acetylcysteine for the prevention of contrast nephropathy. So, these are maintaining adequate intravascular volume is important. So I actually do tend to use sodium bicarbonate. N-acetylcysteine is cheap and not harmful. So at the Brigham, we are still using it for patients who are at high risk. There is a 8,000 patient trial that's being started by the VA, where a 2x2 factorial design, sodium bicarbonate and N-acetylcysteine in patients with chronic kidney disease. So I think in about 5 years, we'll have a definitive answer.
Sas, you want to just take some of the questions
Sure,
that were asked again?
I'll take one. One question was on the importance, indications, and yield of urine eosinophils in acute kidney injury. We order urine eosinophils when we're concerned about the possibility of interstitial nephritis. And it turns out, if you actually study this using kidney biopsy as the gold standard, urine EOs have extremely low, both positive and negative predictive value. So not a great diagnostic test, but probably one of the only diagnostic tests non-invasively that we have for acute interstitial nephritis. So you have to be aware of the false positives. So of course, urinary tract infection can present with eosinophiliuria, so can glomerulonephritis. So not a specific or a sensitive test, but probably the best one that we have outside of a kidney biopsy.
Alan, any questions you want to take?
Yeah. So there's one question here about, in the setting of leukocytosis and hypokalemia, does the serum potassium tell true hypokalemia? And the answer is yes. So that's what's in a lot of textbooks. That the plasma, I think we should say. So most of us do a serum potassium. If it's high, you can also check a plasma potassium, which is one where you have the blood in a heparinized tube, so the blood doesn't clot. And sometimes the potassium will be normal in there. The reason I didn't mention that is because there have been a few recent case reports where the plasma potassium has also been high in pseudohyperkalemia, or conversely, the plasma potassium has been high and the serum potassium has been low. And so the current recommendation is probably the whole blood potassium, and the blood gas analyzer is probably the most reliable method. There's a question about, can we use spot urine potassium to diagnose hypo and hyperkalemia? I didn't mention that to you because for the purposes of the boards, they won't give you that, because just the potassium concentration is not going to help you. And the reason is because hypo and hypokalemia not only affect the urine potassium, but also the concentration of the urine. For example, patients with hypokalemia often have dilute urine. So the urine potassium concentration can be high, low, or normal. There are ways of doing this with a potassium to creatinine ratio, or with a transtubular K gradient calculation, or so-called TTKG, but probably don't have time to get into that, but you'll see those in some of the textbooks. Do I have time for one?
One last one.
And the last one that was asked is, how often does beta blocker cause hyperkalemia? To be honest, I've rarely seen that as a major cause of hyperkalemia by itself. It should only occur with non-specific beta blockers like propranolol, which we don't really use a lot of anyway.
Kevin, couple of quick questions. They've got to be quick now because we're running out of time.
So one question is, how do you treat the anemia of CKD and sickle cell disease? I would say the first thing is to remember that most patients with sickle cell disease have iron overload from multiple blood transfusions, so do not need the use of intravenous iron. I would use the lowest dose of an ESA needed to maintain the hemoglobin at a level that will keep the patient asymptomatic. You don't need to try to normalize their hemoglobin or hematocrit. Another question, to calculate the renal dose of antibiotics, which GFR calculation should be used. I would use the MDRD equation with the caveats I stated about the MDRD equation. You run the risk of probably underdosing if you're using the MDRD equation for estimating GFR in patients who have a relatively normal serum creatinine. But for patients with more established forms of chronic kidney disease, I would use the MDRD equation.